Hello everybody, so we are going to talk here about stroke syndromes. On the other set of slides I talked about diagnosing a stroke, managing a stroke, post-emergency management of stroke, and different things to decide, as well as outpatient care. Here we're going to talk more about how to determine where the stroke is in as much as the circulation based on the symptoms the patient has. So this is going to be more intense on the neuroanatomy. We're not going to talk so much about treatment or diagnosis, but more so clinical appearance. So let's get going. So just to recap some of the fundamentals, there's about 800,000 people every year in the U.S. who have strokes. Many of them are recurrent strokes. About 90% of those 800,000 are ischemic strokes. The other 10% are hemorrhagic strokes, generally due to a bleeding aneurysm, usually a berry aneurysm. Remember that there is a mnemonic for who the people that are predisposed to berry aneurysms, and that's SHAME, S-H-A-M-E. S for smoking, H for hypertension, A for adult polyposis kidney disease, M for Marfan's, and E for Ehlers-Danlos. So, although we tend to stereotype stroke as a disease of the elderly, and it generally is, about 1 in 5 strokes, 18%, are in children and in young adults. So we cannot exclude stroke just because of age. Some of the things on the differential diagnosis for stroke include the post-ictal state, which is after a seizure. You can have something called Todd's paralysis, where, for instance, you may not be able to read, you may not be able to see, you may not be able to move a certain limb. That can happen, and so that can be confused with a stroke. Only difference is these are people who've had a seizure. It can be confused with migraine headache auras that can cause changes in the visual field. It can be confused with vertigo or Meniere's disease, multiple sclerosis, conversion disorder, malingering, cerebral infection, and brain tumor. So those are some things to keep in mind. Of course, stroke is deadly. Most of these other ones are not deadly, at least acutely. So it's very important whenever a patient has acute neurologic signs, acute focal neurologic signs, that stroke is at the forefront of your mind and that you can rule it out. These are just some risk factors in the United States for stroke and the percentage of people that have them. So hypertension, hyperlipidemia are two of the big ones that most people have. Then there's other risk factors such as a previous stroke, a previous myocardial infarction. Both of those sort of go towards hyperlipidemia, diabetes, atrial fibrillation, and so on and so forth. So the most prevalent symptoms of stroke include facial drooping, one-sided arm or leg weakness, verbal deficits, which could be slurring, dysarthria, aphasia, verbal agnosia, meaning that verbal agnosia being you can hear speech but you can't understand it, and then altered level of consciousness. Most patients will have at least altered level of consciousness. However, we're going to see that there are lots of different places where you can get strokes in your brain, and not all of them have these signs. So it's important to know the different syndromes of strokes. Not all of them are the stereotypical facial drooping, one-sided arm and leg weakness or arm or leg weakness, verbal deficits. Some of them don't have any of them. So as I mentioned, other symptoms can be present as well: ataxia, visual field deficits, imbalance, vertigo, and so forth. And of course, that's just going to depend on where it is in the cerebral or cerebellar circulation. Provided that the patient is stable to outrule stroke, the best initial diagnostic step is going to be a non-contrast CT of the head. You really can't go wrong by doing that as long as you have a stable patient. If a patient has acute focal neurologic deficits, a CT is going to be useful no matter what, because another possibility could be injury. And in that case, then, of course, we're going to want to have a CT then. So a non-contrast CT of the head is the best initial diagnostic step in patients where we're suspecting stroke. Of course, we always have to stabilize the patient first. So don't be thinking that I'm saying this is always the best first step. This is the best initial diagnostic step. Okay, stroke and TIA. So let's just quickly gloss over how we diagnose and treat it. We're not going to spend the bulk of the time on this lecture talking about that. So history, hypertension, hypercoagulability, hyperlipidemia, those are the three big ones. Diabetes, obesity, and amyloid angiopathy are sort of at the periphery. So hypertension is the #1 risk factor for stroke. And symptoms of stroke, as mentioned, is altered level of consciousness, facial drooping, one-sided arm or leg weakness. Usually it's on one side of the body or the other. You could have verbal deficits or gait disturbances. Certainly you're not going to have all of these. You may just have one or a couple of them. It all just depends on where the stroke is. And you should always consider stroke in a patient with acute onset focal neurologic deficits regardless of the age. The initial diagnostic step is always going to be a non-contrast CT. This has to be done for two reasons. One, because we're looking for a stroke. Two, because we need to know what kind of stroke it is if there is one. So the CT is going to help us differentiate between an ischemic stroke or a hemorrhagic stroke, and that's going to be really important as far as how we manage the stroke. We also need to have routine labs, particularly including glucose and the INRs. And that's because if the patient has an ischemic stroke, one of the possible ways we can treat them is TPA, alteplase. And in order to use TPA, one, it has to be an ischemic stroke, obviously. And two, they need to have normal INRs. And three, they need to have a glucose of greater than 50. Any glucose less than 80, we're going to treat with supplemental glucose. But we need to make sure that the patient is euglycemic because that is a necessary condition in order to treat the patient with alteplase, with tissue plasminogen activator, TPA. And that is the most preferable treatment for any patient with ischemic stroke. And then, of course, we should always have an EKG on any patient with a stroke as well because we're looking for atrial fibrillation. If the patient has atrial fibrillation, then our management is going to be different. The acute management will be the same, but the long-term management will be to treat the patient for atrial fibrillation. Many patients with stroke have atrial fibrillation, so an EKG is certainly worth getting. Emergency treatment is going to include supplemental oxygen. Remember, just your ABCs right there. Blood pressure control. We tend to use labetalol. Of course, if we're going to do TPA, as you know, if you watched the previous, the first stroke lecture, we need to get their blood pressure below systolic 180. Any patient, though, we should get their blood pressure below systolic 220. And then, as mentioned, treat hypoglycemia if their glucose is less than 80, and treat fever if they are febrile. Now, while the initial diagnostic step is always a non-contrast CT, the most accurate test is a diffusion-weighted MRI. MRI is always more accurate than CT, but we're not going to do an MRI because it takes a long time. It takes like half an hour to an hour to get an MRI. And we need to get these patients with possible strokes diagnosed and treated as quickly as possible. They're losing millions of neurons a minute. So we never do MRI to diagnose a stroke. We may do it to assess a stroke after we've treated it, but we always do the non-contrast CT to diagnose the stroke. Never MRI. So here's some CTs of hemorrhagic strokes and of ischemic strokes. So these two on the left here are both hemorrhagic strokes, and the way you can tell is that you can see the blood. So here we can see blood in the ventricles. It's not always in the ventricles. Sometimes you just see it in the brain tissue itself, but ultimately it can seep into the ventricles. So this white here on the CT is ventricle. That's why we don't use contrast, because if we used contrast here, we wouldn't be able to tell if there was blood. It would look white no matter what. So here's an ischemic stroke. The way you can tell an ischemic stroke is that you have a blurring of the white-gray matter. So the white matter and the gray matter, you can't really see the difference. Look at on the left side here. This is patient's left here and patient's right. See, you can see your gyruses here, but you can't see them here. You've got just generalized inflammation, and so that's what's causing the white-gray matter. The white-gray matter look the same. Same thing here. You see a difference. You don't see you see it's dark. It's darkened here. I'm not a radiologist, so if you haven't been able to tell, but again, it's one way to tell, no matter what, is if it looks different from the other side, there's probably something wrong. Another way you can tell is an ischemic stroke is if the white matter becomes darker. Okay. And then here's another ischemic stroke. So again, you lose your differentiation between the white and gray matter. You can't see those gyruses as nice. And this is an MCA stroke. Okay, so let's just briefly go over the arterial circulation of the brain. Remember, we have an anterior circulation, both coming from the internal carotid artery that comes directly off of the heart. On the left side, it comes from the arch of the aorta as the common carotid artery, and on the right side, it comes from the innominate artery. Then the common carotid splits off into the external and internal carotid artery. Internal carotid artery continues. It gives off the MCA, which is the middle cerebral artery, and the ACA, which is the anterior cerebral artery. It also gives off the ophthalmic artery. Now, something really important is that the internal carotid artery also gives off a communication artery, and that communication artery goes to the posterior circulation. So your posterior circulation is coming off from your anterior spinal artery and your vertebral artery. They come together and merge to form the basilar artery. The basilar artery gives off pica, which is your posterior inferior cerebellar artery, and it gives off AICA, which is your anterior inferior cerebellar artery. It continues as the basilar artery and gives off pontine branches, and then it gives off bilaterally superior cerebellar arteries, and then it splits to form the posterior communicating artery, and that gives off your posterior cerebral artery, and it communicates with the posterior communicating artery that the internal carotid artery gave us. So we get blood from both sides, posteriorly and anteriorly, but they're communicating through this posterior communicating artery and the anterior communicating artery, which connects the circulation from left to right. And then this is just another way of looking at it from the side here. You can see this is our circle of Willis here, the posterior communicating artery, the ophthalmic artery, the ACA, MCA, cerebellar circulation, and so forth. Okay, so when you're looking at the brain, there are a couple landmarks. And while I don't have a brain here to show you, there's a central sulcus, which is a very deep sulcus right between the frontal and the parietal lobes. That landmark is important because in front of it is going to be your sensory cortex, and behind it is going to be your motor cortex. Now, when you take a slice of the brain, so here we are looking at it from the side, and now imagine taking that slice, and now you're looking at it in the front. So this is medial here, and this is lateral out here by the orange. So lateral coming up superiorly, and then moving down, and this is medial down on this side. So the homunculus corresponds somatotopically to the body. And you can see that there's sort of a pattern on how it goes. So you have your tongue and your jaw and your lips. So your lower face, your lower face, and then your eyes and your brow, your upper face, and then you've got your fingers here taking up a pretty good chunk, and your hands and your upper extremities. So your upper extremities and hands and fingers and your face take up over 2/3 of the cortex. That's a lot. And that makes sense because your face and hand, you need to have more control over those parts of the body for manipulating objects and so forth, for speaking. Your hip, lower extremity, and genitals get the rest of it. And this is going to be important when we talk about MCA versus ACA strokes. So your MCA, your middle cerebral artery, contrary to its name, your middle cerebral artery runs laterally. So your middle cerebral artery feeds this part of the motor cortex. So your upper extremity, hands, fingers, face. On the other hand, your anterior cerebral artery runs in the middle, and it's going to feed your hip, lower extremity, and genitals. So that's the reason why with the middle cerebral artery stroke, it gives you different symptoms than an anterior cerebral artery stroke. And this will come together in the next few slides. Okay, so this is just looking back on the arterial circulation of the brain. Okay, so I want to give you one more look at the blood supply of the brain, just to, not to belabor this too much, but I do think it's important to know. So your anterior cerebral artery is primarily taking care of your frontal lobe and the midline of the brain. Your middle cerebral artery is primarily taking care of the superior portion of the temporal lobe, the rest of the frontal lobe that your ACA is not taking care of, and your parietal lobe. And then the ophthalmic artery is part of the anterior circulation, but you can't see it here. Now, at the posterior circulation, your basilar and pontine arteries are taking care of your brainstem. Your anterior inferior cerebellar artery are taking care of your anterior inferior cerebellum, just like the name implies. Your posterior inferior cerebellar artery, pica, takes care of the posterior inferior cerebellum and also has some role with the lateral medulla. The superior cerebellar artery takes care of the superior cerebellum, and the posterior cerebral artery takes care of the posterior cerebrum, the posterior part of the brain. So the inferior part of the temporal lobe and the posterior part of the occipital lobe, posterior part of the parietal lobe and the occipital lobe. So it's taking care of the back, just like its name implies. Okay, so let's talk about what this section is about, and that is the types of strokes you can get. So we're going to talk about 7 different kinds of strokes. MCA stroke, ACA strokes, PCA strokes. We're going to talk about 2 different kinds of PCA strokes that are from deeper arteries of the PCA. And then we're going to talk about pica stroke. We're not going to talk about basilar artery stroke. Basilar artery stroke is the locked-in syndrome. We'll mention that in a different section. You probably know what locked-in syndrome is, so if you don't, feel free to ask. Okay, so the middle cerebral artery. Middle cerebral artery stroke is the most common. It affects the upper body more than the lower body, and that just goes back to that homunculus. Remember, the middle cerebral artery is taking care of the lateral parts of the brain. The lateral part of the homunculus was the upper body. So it affects the upper body more than the lower body. It also causes some lower facial paralysis. Why? Because the lateral part of the homunculus takes care of the face. And so you can get a little bit of facial paralysis. Why just the lower face? The reason is because the upper face has bilateral innervation, whereas the lower face just gets unilateral innervation. So if you affect the face, it's only going to affect the lower face. The upper face will be fine because it still has innervation from the other side. So ipsilateral lower facial paralysis. And this is ipsilateral because all the innervation for the face goes straight to the face. You're not going through any decussations. Now, your body paralysis or sensory loss is going to be contralateral, and that's because this lesion is before the motor decussation. So you've got your lesion in the cerebral cortex, and the nerves go down and then they decussate. And so the left part of the homunculus takes care of the right the right side of the body, and the right cortex takes care of the left body. So you're going to have ipsilateral lower facial paralysis and contralateral body hemiplegia and sensory loss. The middle cerebral artery also affects the nerve that innervates the muscles in the ipsilateral eye, and so this results in a bilateral eye deviation towards the side of the infarct. Why towards the side of the infarct? Well, this is kind of more of a complicated reason, and we'll see when we look at some of the different kinds of posterior cerebral artery strokes. But there are 6 muscles in the eye, 4 that are really important, and 3 of them are innervated by this third cranial nerve, the oculomotor nerve. The other one is innervated by a nerve called the abducens nerve. When you get an MCA stroke, you can get it can affect the oculomotor nerve, but the abducens nerve remains intact. Now, the abducens nerve is responsible for moving your eye laterally. And so if you have a stroke that affects your third nerve, then the only way you're going to be able to move your eye is laterally. And so it's going to pull your eye towards that side. And so the abducens nerve of whichever side you had the stroke on is still working. So if you have a right MCA stroke, your right oculomotor nerve is not working, but your right abducens nerve is working. And so going to your right eye, because these don't decussate, you're going to have no oculomotor input to your right eye, but you're going to have normal input to your from your abducens nerve to the lateral rectus. That's going to pull the eye laterally. And by reflex, when your right eye moves laterally, your left eye moves towards that side, so it would move medially. And same with your left eye. If your left eye were to move laterally, your right eye would move towards that side. You can't move your left eye laterally and your right eye laterally at the same time. So that's just a really complicated way to explain that when you have an MCA stroke, it can affect the ipsilateral eye, the eye on the side of the stroke, and you will have deviation of the eyes towards the side of the infarct. So if it's a right-sided MCA stroke, your eyes will be deviated to the right. An MCA stroke can cause contralateral homonymous hemianopsia, but that's rare. If the stroke is on the left side, it can and usually does affect language, both reception of language and production of language, or one or the other. It can also give verbal agnosia. So this has to do with Broca's and Wernicke's area, but you can have language deficits in addition to your paralyses. Now, I would think that it's pretty important to differentiate out that you can have motor deficits of the facial muscles, and so that can cause slurring. It doesn't necessarily mean that you have a stroke of the language centers of the brain. So make sure if you see a patient that appears to not be able to speak properly, make sure that it's not because they can't move their facial muscles properly. Okay, here's a MCA stroke. You can see that we've got nice white gray matter differentiation here on the left side of the patient, but on the right side we have none. Here's another one. Again, on the right side here. Okay, anterior cerebral artery stroke. So this is going to affect the lower body more than the upper body. The anterior cerebral artery supplies more of the midline and the front of the brain. And so that's going to affect the legs, the hip, and the feet. We can also, also get contralateral body hemiplegia and sensory loss, but this is unlike the MCA stroke. The ACA stroke is going to be lower body. Because there are some voluntary muscles of your motor cortex that are responsible for urinary continence, you may have weakness of pelvic floor musculature and urinary incontinence with an ACA stroke. So that's sort of a unique finding that you don't see in the MCA stroke. Some less common manifestations include anosmia, and that's because the olfactory bulb is right in the middle of the brain, and so if that loses oxygen, it would dysfunction, so you'd have a decreased ability of smell. And personality change, and that's because the frontal lobe is responsible for a lot of different quirks in our personality. So if you have a defect to the frontal lobe, it can cause personality change. But most saliently, what you're going to see in the anterior cerebral artery stroke is lower body hemiplegia and sensory loss, as opposed to the MCA stroke, where you see upper body hemiplegia and sensory loss, and also the verbal issues. So here's an ACA stroke. You can see that our area of interest is right here. Here's another one. This is more towards the midline, probably a penetrating branch of the ACA. Okay, so how about PCA strokes? So remember, the posterior cerebral artery is the last branch of your posterior circulation before it anastomoses as the posterior communicating artery. PCA strokes are generally visual. Why is that? Because the posterior cerebral artery supplies your occipital lobe, and your occipital lobe is responsible for vision. It holds your visual cortex. So the most salient features of PCA strokes are visual. There are no PCA strokes that don't have some kind of visual component. Now, in a true PCA stroke, there are never motor symptoms, and I would expect that on the USMLE you will have a true PCA stroke if they're asking you for a PCA stroke. The primary visual cortex is affected, and this results in a contralateral homonymous hemianopsia. And you might be confused as to what this contralateral homonymous hemianopsia is, or you might not remember. Certainly if you don't work in neurology or emergency medicine that frequently, you don't see a whole lot of it. So we're going to give a quick review of the optic tract in a little bit. PCA strokes can also cause visual hallucinations, so seeing things that aren't there. Or visual agnosia, so you see things but you don't know what it is, and that the visual agnosia tends to be more with the the interface between the occipital and parietal lobe. So remember, our occipital lobe sees things, our temporal lobe hears things, but it's our parietal lobe that kind of helps us figure out what it is that we're hearing and seeing. So if you have damage closer to the parietal lobe on the occipital lobe, but higher, closer to the parietal lobe, you may have this visual agnosia where you can see the thing, but you don't know what it is. Okay, so here's our visual tract. This is going to explain why we get the visual deficit we get in a PCA stroke. So here's your eyes, right here. Here's your left eye and your right eye, and this is the field you're looking at. So your left eye, rather, always is looking at your, let's see, okay, so your left eye is always looking at your, at the left side of the visual field. And your right eye is always looking at the right side of your visual field. That makes sense because your left eye is on the left side and your right eye is on the right side. Now the medial side of your eye always looks temporally. So it always looks off laterally to the side, whereas the lateral side of your eye always looks nasally. It looks down your nose. It looks towards the middle of the field. So what we see here is we see that this side of the left eye is getting this part of the visual field. This red side is getting this portion of the visual field. This red part is getting this part of the visual field, and this blue part is getting this part of the visual field. Okay, this is always how it is in everybody. Now these give off neurons at the retina, and it forms the optic nerve. And the optic nerve is what provides all of our information about what we see. After the optic nerve, what happens is the temporal sides, so this side here, so the left part of the visual field in the left eye, and the right part of the visual field in the right eye, they cross. So you have a decussation, and that's called the optic chiasm. So what you have then is this optic tract. And the optic tract on the left side is carrying the right part of the visual field for both eyes. So here you can see the red part, which is the right part of the visual field for both eyes, crossed from the right eye to the left eye. So your left eye is carrying the right part of your visual field, or the right part of each visual field for both eyes. So it's carrying this and this. And the right eye is carrying the left part of the visual field for both eyes. So it's carrying this here and this here. These, the ones that the blue are connected to. Okay, so we have the optic tract. The optic tract then goes to this LG body, lateral geniculate body. And that gives off these radiations, which then go to your primary visual cortex. And the primary visual cortex organizes all of that and gives you your image. Now we'll talk more about the optic radiation and this whole pathway in a different section when we talk about neuro-ophthalmology, but for now this will do. So what happens when you get a PCA stroke? Well, your PCA takes care of your primary visual cortex, which is part of your occipital lobe. If you get a PCA stroke, you lose that visual cortex. And so if you've lost the visual cortex on one side, you've lost one side of both visual fields. So you've lost, in this case, it was the left, so you've lost the left side of both visual fields. And so that is homonymous hemianopsia. Homonymous meaning both sides. Hemianopsia meaning half of the fields. So half being the right part of the left-sided field and half the right part of the right-sided field. So homonymous hemianopsia. And it's a contralateral homonymous hemianopsia because while it happened on the left side of the brain, the stroke, you've lost the right fields of vision. And if you do this map and you do it with the blue side, you'd see you would lose this part and this part. And so you would have a left homonymous hemianopsia due to a right PCA stroke. Now, when you get into neuro-ophthalmology, it becomes really interesting because, well, what happens if you get a lesion here at the optic tract, or here at the LG body, or here at the optic chiasm, as you often do if you get a tumor, or if you have a lesion of the optic nerve? It's going to be different. So this is just, homonymous hemianopsia is just one form of visual field deficit you could have. And it is the visual field deficit. Contralateral homonymous hemianopsia is the visual field deficit that you get when you have a PCA stroke. Here's a PCA stroke. So you can see we lose our white-gray boundaries on the posterior side of the brain. And this is a left PCA stroke. So this person would have right homonymous hemianopsia. Okay, let's talk about some strokes involving the oculomotor nerve. So the strokes involving the oculomotor nerve cause oculomotor palsy or ophthalmoplegia. The ones we're going to talk about there are two of them, and they both involve the deeper branches of the PCA. So rather than having a stroke of the whole PCA, what you have here is you have a stroke of a particular penetrating branch of the PCA that innervates the rostral midbrain. So rather than having a stroke of the PCA that's affecting the occipital lobe, you're getting a stroke from a branch of the PCA that innervates the midbrain, because there are parts of the midbrain that are fed by branches of the PCA. So these two conditions we're going to talk about are strokes that involve strokes to that part, to the midbrain. So these are midbrain strokes. Up until now, we've only been talking about strokes to the cerebrum. Now we're going to talk about strokes to the midbrain. And these are both strokes that happen at the level of the ophthalmic nerve. Okay, so the ophthalmic nerve innervates 4 of 6 muscles responsible for eye movement. Remember I said it innervates 3 of 4 important muscles? Well, it innervates 4 of the 6 total muscles. So you have, in your eyes, you have 4 recti muscles: superior rectus, inferior rectus, medial rectus, and lateral rectus. And then you've got superior oblique and inferior oblique. And these oblique muscles, they do a little bit of extra work on the side, but it's these 4 recti muscles that are the most important. So cranial nerve 3, the oculomotor nerve, innervates the superior rectus, the inferior rectus, and the medial rectus. It innervates all the rectus muscles except for the lateral rectus, which is, if you were paying attention a few slides earlier, is innervated by the abducens nerve. The oblique muscles, the inferior oblique is innervated by the CN3, but the superior oblique is the only muscle innervated by the trochlear nerve. So if you have a CN3 palsy, you're going to lose innervation to all of the muscles except for the lateral rectus and the superior oblique. Now, what do these muscles do? The superior rectus elevates your eye. It allows your eye to move up. So if you're looking up into the sky, that's your superior rectus doing that for you. Your inferior rectus depresses your eye. So if you look down at your shoes, that's your inferior rectus doing that for you. Your medial rectus adducts your eye. So if you look at your nose, the eye that's looking at your nose is being moved by your medial rectus. Your lateral rectus helps you look off to the side. So if you look off to the side, that eye that's looking off to the side is being moved by the lateral rectus. The superior oblique and the inferior oblique help you move your eye when it's at full medial position. So if you're looking at your nose and you want to move your eye up or down, those oblique muscles are there to help you do that. So if you're looking at your nose and then you look straight up, that's your superior, that's your inferior oblique moving your eye. So the inferior oblique elevates and the superior oblique depresses. So they're counter to their name, unlike the recti muscles. Okay, so why is this important? If you lose CN3 and all you've got is CN6 and CN4, then all you've got is your lateral rectus and your superior oblique. So the eye is going to move out because it's going to be abducted. You've lost all your other rectuses, and your superior oblique is going to depress it. So you can still abduct and depress, and that's all you're going to do because your other muscles just become limp. And so what you get out of that is the down and out eye. So remember, cranial nerve 3 is the superior rectus, medial rectus, inferior oblique. Cranial nerve 4 is the superior oblique, that's the trochlear nerve. Cranial nerve 6 is the lateral rectus. when you lose cranial nerve 3, all you can do is depress your eye and abduct your eye. So this eye is down and out. And this is a sign of ophthalmoplegia, or cranial nerve 3 palsy. Now, this LPS muscle, what is this? This is the levator palpebrae superioris. That is the muscle that holds your upper eyelid open. That's also innervated by your third cranial nerve. So if you lose your third cranial nerve, you're also going to have a heavy eyelid because you can't raise that eyelid up. And so that's why this guy's eye is shut. It's not because he got hit, it's not because he's tired, it's because he can't lift that eyelid up. Levator palpebrae superioris cannot raise the lid because it doesn't have innervation. Another thing I thought I'd just mention real quick is that the superior rectus is also responsible for intorsion of the eye, and the inferior, or sorry, not superior rectus, superior oblique is also responsible for intorsion of the eye, and the inferior oblique is also responsible for extorsion of the eye, but that doesn't really come into play here. Okay, so here's another down and out eye. Alright, so the two CN3 palsy strokes are Weber syndrome and the more severe Benedict syndrome, and they're both due to penetrating branches of the posterior cerebral artery that go into the rostral midbrain. So we'll start talking about, let's first start with talking about the rostral midbrain. The rostral midbrain, at the point that that these strokes happen, are not surprisingly at the level at which the third cranial nerve comes out. And so that's why it affects the third cranial nerve. Other things that we have in the midbrain here, we have our corticopontine tracts, substantia nigra, and red nucleus. Remember, those are responsible for very coordinated motion. Substantia nigra is implicated in Parkinson's disease. You have your lateral spinothalamic tracts and your ventral spinothalamic tracts. That's your pain areas. So that's how you get pain and temperature up from the peripheral nerves. Then you've got your medial lemniscus. That's part of the DCML system. So that's carrying fine touch and proprioception up to the thalamus. And then you've got your cerebral aqueduct right in the middle here, which is continuation, and you've got your colliculi on either sides here. Okay, and then your pyramidal tract right here. I don't know if I mentioned that. So your pyramidal tract is carrying your upper motor neurons. All right. So the first disease to talk about, the first midbrain stroke, is Weber syndrome. And Weber syndrome is a blockage of a penetrating branch of the PCA that feeds the midbrain, and it goes up to the red nucleus. So we don't have any red nucleus involvement. The only place that there's involvement are the pyramidal tracts and, to a lesser extent, the substantia nigra, and of course the third cranial nerve. So the two parts that are most important here are the third cranial nerve, which gives us the ophthalmoplegia, and the corticospinal tracts, the pyramidal tract. So the ophthalmoplegia is going to be ipsilateral. There's no decussation of the third cranial nerve. So you're going to get an ipsilateral oculomotor palsy. So you're going to have that down and out of, in this case, it's the left side. So you're going to get a down and out of the left eye and a heavy left lid. And we also have damage to the pyramidal tract, the corticospinal tract, and that is going to cause contralateral hemiplegia. And the reason it's contralateral is because it hasn't decussated yet. So this is carrying nerves from the left cortex, but it's going to decussate at the medulla and it's going to go over to the right side and provide it's going to provide innervation to the right musculature. So even though the stroke is on the left side here, because it hasn't decussated yet, you're going to have right-sided contralateral hemiplegia. So ipsilateral oculomotor palsy and contralateral hemiplegia. Now, yes, you are affecting the corticopontine tracts, and you are affecting the substantia nigra. That's going to be a little bit lesser as far as symptoms go, but the substantia nigra can cause some gait disturbances. You can have some Parkinsonian effects. But primarily with Weber's syndrome, what you're going to see is ipsilateral oculomotor palsy and contralateral hemiplegia. Okay. Now, Benedict's syndrome is a little bit more severe. So Benedict's syndrome is really, you can think of it as Weber's syndrome plus effect of the red nucleus and more substantia nigra. So look at the difference here. It's just affecting more of the midbrain. So again, we have our oculomotor palsy. It's going to be ipsilateral. But we're also going to have, in addition to our contralateral hemiplegia, we're also going to have some severe gait disturbances, and they're going to be contralateral. So that's because of the effect on the red nucleus, and the red nucleus helps us with gait, and the substantia nigra as well. So you combine the two of those together, and you're going to have severe gait disturbances. So the way you can think of it is Benedict's syndrome is just Weber's syndrome with more severe gait disturbances. But they both have in common that ipsilateral oculomotor palsy. So if you've got a patient that's got oculomotor palsy, you should be thinking of a midbrain infarct. Okay, so lateral medullary syndrome, or Wallenberg syndrome. This is the last one. This is an infarction of the posterolateral medulla, and it's due to blockage or hemorrhage of the pica, posterior inferior cerebellar artery. So, as mentioned, the pica primarily supplies blood to the posterior inferior cerebellum, as it says in its name, but it does give a little bit of blood to the midbrain and or to the brainstem. Sorry. Okay, last one. So Wallenberg syndrome, or lateral medullary syndrome, is an infarction of pica. Now, pica primarily is giving blood to the posterior inferior part of the cerebellum, but as it branches off, it is also giving off branches to part of the medulla. So if you get a blockage of pica very proximally, you can get an infarct of the lateral medulla. It's not very common, but it's such a stereotypic question that it's common on the USMLE because of the anatomy and the neuroanatomy that it implicates. So the salient features are ipsilateral facial sensory loss and contralateral body sensory loss. Where else are you going to see that? So if you have ipsilateral facial sensory loss on one side of your face, and on the other side of your body you've got sensory loss in your body, that is Wallenberg syndrome. It also tends to be accompanied by dizziness, ataxia, dysarthria, and Horner syndrome. And those are for various reasons, which I will explain in a little bit. So here is your inferior medulla, approximately where the infarct, where it would affect. So here's this little diagram. It kind of looks like a little butterfly here, but I drew out the important landmarks. So this is anterior down here, or ventral, and this is posterior here. Okay, so in red here you've got your corticospinal tracts. These are your pyramids that are supplying your motor function. So these are upper motor neurons going down to their lower motor neuron destination. This is the medial lemniscus, so this is part of the DCML tract, responsible for fine touch, proprioception, and sensation. This is the medial longitudinal fasciculus. This is for vision. We'll talk about that in a different section. This here is your hypoglossal nucleus, and this gives off your hypoglossal nerve. You also have these three in the pink here are part of your vagal nerve, and they give off they give off projections which form the vagal nerve. Solitary nucleus, dorsal motor root, and nucleus ambiguus. This here is the inferior olivary nucleus in green here, and this is responsible for coordination. Now, let's get into this yellow region, because this yellow region is the region that is affected when you have Wallenberg syndrome, because it is fed by the posterior inferior cerebellar artery. First, we have our spinothalamic tract. The spinothalamic tract is sensation, and it is this is the second order neurons. But remember, with the spinothalamic tract, it's the only tract that crosses right away. It crosses at or about at the level of the vertebrae. So if you have a problem anywhere in the vertebrae, basically, to the spinothalamic tract, it's pretty much always going to be contralateral because it crosses so quickly. So this spinothalamic tract here on the left side, this is the left because this is anterior, this is actually carrying fibers for the right side of the body. So if this part is affected, you get contralateral sensory loss. Now here's your tract of your CN5, and that's your trigeminal nerve. Now this is coming in ipsilaterally, this is coming in contralaterally as well. So now with this one, you've got this is helping you move your jaw. So with that, if that's affected, that causes your dysarthria. Now your dizziness and ataxia are caused by a loss of the vestibular nucleus here, and this helps you with balance. Okay. So, but as far as Wallenberg syndrome, just remember ipsilateral facial loss, contralateral body sensory loss. Lateral medullary syndrome or Wallenberg syndrome is a sensory disease. So you're not going to have any paralysis here. But you can have some weakness of some muscles just because you do have some cranial nerves coming off. You're not going to have any body weakness. If you have any weakness, it's going to be facial. And then this is just a recap. I put the ones here in bold and blue, the ones that really are more of the giveaway. So the MCA stroke, the upper body and facial droop, verbal deficits. With the ACA, it's lower body. Posterior cerebral artery stroke, you get the contralateral homonymous hemianopsia, also visual hallucinations, and you don't have any motor or sensory effects. Weber's and Benedict's syndrome, you get the ipsilateral oculomotor palsy. Benedict's is just a little bit more severe as far as the gait disturbance. And Wallenberg syndrome, you've got the ipsilateral facial sensory loss and the contralateral body sensory loss. You can also get dysarthria and vertigo. And that is it.